right. Hello, everybody. I don't know how many times I've been coming to this meeting, but it's been said before, this is actually my favorite meeting of the year. It's the only meeting I go to where the patients, the providers, and the caretakers are all in the same room, which is honestly amazing and inspiring. I have to say both the talk today and yesterday that we had from patients and caregivers were so impactful. And honestly, I think that makes people need to hear the story. So I thank you for having the courage to stand up and talk about it. I think most of what we talk about, a lot of the studies we've seen are adult-based, but there are still a number of children who have desmoid. And we thought each year, at least, we try to kind of focus a little bit on the pediatric population. It's an important population. I just wanted to talk a little bit about some of the short and long-term complications that we think about for children. And so basically, just a quick overview of desmoid tumors in children, then some of the treatment considerations, some options in children, some of the short and long-term side effects, and then maybe some of the directions that we're trying to go. So we don't really know the true incidence of desmoid in children. 15,000 children are diagnosed per year with cancer. And of those, as you know, we've talked about the definition of cancer, but in terms of the realm of sarcoma, at least, we think about desmoids being less than 0.1% of all the cancer that we see. The peak incidence, there is an increased incidence between 6 to 15. And then obviously we've talked about the female, mostly predominance during puberty into 40 years of age. Interestingly, in children, there's actually a bit of a slight male predominance, but female is typically more prominent during adolescence. So most of the time, similar to the adult population, we actually don't really know why desmoids form in children. There are non-inherited forms like trauma, which does precede some of the desmoids we see in children, but maybe in about 1/5 of the cases, but not the majority. There are inherited conditions, but these are not the majority either, like FAP that's been discussed before, that's due to a specific mutation. And these usually appear in the abdomen, in the abdominal wall or mesentery has been described. And then Gardner syndrome is another one that's like FAP, but most of the time we really don't know. So also there's a relationship between the tumor location and age, such that those that younger tend to have head and neck primaries compared to the torso or the limb that we see in maybe older children. So there is something about the head and neck that seems to predispose more to the younger children. But that's really, I mean, what I summarized is really what we know about desmoid tumors in children. So we think we have a lot more to learn. There are some practical considerations, though, that we need to think about for children. One, there's less known about the behavior of desmoid tumors in children. Adult treatment recommendations might not be able to be transferable to children. Many of the therapies are less tested compared to adults. And so when we think about treatment options in the pediatric population, considering some of these important caveats, we think about surgery, and as has been talked about, we feel the same way. Historically, it was used for the treatment of desmoid tumors in children. However, as mentioned, there's a high recurrence rate, even if you remove the whole thing. It's also difficult to remove the entire tumor without leaving anything behind in a smaller child. And there's a lot of long-term disabilities that children face. Radiation was just mentioned during the tumor board, and although it may be a treatment modality for adults, we rarely consider it in children because of the long-term complications, as was mentioned. These children have many years ahead of them to live, and so deformities, disfigurements, stiffness, effects on bone growth, secondary cancers are all real things that so I would say surgery and radiation generally are not considered frontline for the pediatric population. So this was a trial that was actually done by our European colleagues, and it was a great trial where they actually looked at active surveillance as a modality for children. It was the first pediatric study that looked at this, and they basically, any patient with stable disease and without symptoms could be watched, and then if they progressed or had symptoms, they would go on to get treatment. And what they saw was that even though there's a little bit of a separation of the curves, generally, statistically, there was no difference between the outcomes for those patients that had watchful waiting versus immediate chemotherapy or surgery, kind of justifying why upfront active surveillance is an appropriate option for children. So the philosophy of therapy in children is that the initial watch and wait is probably standard of care for initial treatment for most of us. I do think there are some caveats, however. So spontaneous shrinkage might not be as common in children compared to adults. Children seem to have more risk factors for growth, such as larger initial tumors and locations like the head and neck that might be more difficult and more aggressive, and risk of longer-term impairment with a tumor that's growing next to it. So I think we need to think about this when we think about active surveillance. So I always like showing this slide. I use this for all my patients, even without desmoids, for those that have sarcomas, just as a way to kind of demonstrate some of the things we worry about. And I think that any therapy we choose has an impact on them, on every part of the body. These children have many, hopefully, years ahead of them. They're growing pretty quickly. They have a higher tumor to body surface ratio. They might be going through puberty. They have developing bones, developing minds, and they have future fertility to worry about. So I think when we think about what treatments and what we want to do for children, I think we need to consider all these different variables in the decisions that we make. So I just want to talk a little bit about the medical therapies in children by breaking into chemotherapy, which are considered cytotoxics, and then targeted therapy that are considered non-cytotoxics. So chemotherapy cytotoxics, vinblastine methotrexate or vinorelbine is probably the most common regimen used in children. We have an international consensus probably that that's first line. It's given weekly, generally for about 6 months, and then every other week for another 6 months. And usually IV, although there are some people giving it by mouth. Doxil or liposomal doxorubicin has been described in the adults. We do use it a little bit in children, but there's very little data. It's given IV every 4 weeks, but once again, not used as commonly. So there's side effects with all these medicines. So for chemotherapy, these are all, I listed here, kind of the list of side effects that you can see. And I think that, when you think about low blood counts, higher risk of infections, needing potential transfusions, risk of infections, it can affect the liver enzymes, nausea, vomiting, mouth sores. So I think short term, there's some concern about the type of side effects that we might see in children. And long term, for vinblastine methotrexate, probably not much of a concern, but long term with doxorubicin, higher risk for heart damage and secondary cancers. So something that we take seriously. I think for the targeted therapy and non-cytotoxics, multi-tyrosine kinase inhibitors have been used. Once again, we don't have as much data on this compared to the adults. Imatinib, sorafenib, and pazopanib are most commonly used, but very limited data overall. Short term, the side effects seem to be about the same that we see in adults: elevated blood pressure, skin rash, diarrhea, somewhat manageable, but certainly can be impactful. And I would say that most of these happen within the first few months or first few cycles, and then tend to dissipate after that if you can kind of get through the beginning part. Long term, I think unknown is probably the biggest one here. You're going to see a theme, but I think we just don't know enough long term for these patients whether or not there are long term toxicities. Possibilities include heart dysfunction, bone weakness or growth, and thyroid dysfunction for tyrosine kinase inhibitors. Gamma secretase inhibitors we've talked about. Nirogacestat is one we've talked about for adults. There's actually a pediatric study that recently closed, and we should have data reported out for that study in the beginning of the 2025 year. And I think we'll have some good information about not only efficacy, but safety for that drug as well. And then AL102 is being studied in adults, but it's not been studied in children, so we don't really have good data about that drug. Short term, it seems to be generally pretty well tolerated with some nausea, vomiting, liver enzyme issues, diarrhea. But once again, we don't know a whole lot yet. And long term, once again, it's somewhat unknown with possible fertility challenges, bone weakness, bone growth abnormalities that we have concerns about. Beta-catenin inhibitors, there's an ongoing study in children looking at tagvivint in children with desmoid tumors and other tumors that have beta-catenin mutations. We don't know a lot about this drug. We think it's going to have some potential bone changes and growth suppression, but we really don't know. And long term, we also don't have a lot of good data about this particular drug. Tamoxifen and Solndac has been described. It actually was studied in children. We did a cooperative group study and looked prospectively at this, and it really wasn't shown to be all that effective. And there were a number of females on the study who got ovarian cysts, and so we really don't use this frontline for most children as a frontline treatment for desmoid tumor. Hydroxyurea is interesting. People use it. It's not well studied. There is limited data in desmoid tumors, but we do have long-term safety, at least, to know that it's safe to use. So some people do use it. And then I just want to mention local control in children. We don't have a lot of good data in this area, but I will say that more and more of us are starting to use things like cryoablation, chemoembolization, radiofrequency ablation, high-frequency ultrasound. So I think this is another good option to consider for patients and children. You just want to make sure you're doing it at a place that feels comfortable and knows how to manage it. So these local control therapies generally seem pretty good. I think short term, depending on which one you use, there could be some issues with the skin, some pain, some swelling, but overall pretty well tolerated. Long term, generally also not much of an issue, but nerve damage is definitely something that you can see with some of this therapy, particular cryotherapy. So you've seen this slide before. This is similar to what we have in the position paper. And I just put it up here to show you that we really have a very similar approach in children like we do for adults, in that when they're diagnosed, they should ideally be seen by somebody or somewhere where they have familiarity with sarcoma, particularly desmoid tumors. And then initially, if they're asymptomatic and doing well, you could actively surveillance these patients with a watchful wait approach with imaging, and then consider treatment for when the tumor is growing or when symptoms develop. But it's the same, we use the same basic model for children that we're currently thinking about in adults. So this is a table that I just put together. This is not a consensus table, but when I was doing this talk, I found it helpful to think about all the different treatments that we think about and use. These are not listed in the order that I would use. It's more of just a list of the treatments that are all I mentioned in my talk. And what I went through is just put here the method, the frequency, duration, generally. Sometimes we don't know duration. Some of the short-term side effects in terms of the more pluses, the more likelihood that there's more short-term side effects. Long-term side effects, effectiveness, and data. And once again, this is not a ranking. It's not necessarily my choices, but the point of the slide is just to show you that when you're making a decision on how to treat children, what to treat children with, I think it's important to weigh everything. Like the method may matter, right? Some people might not want a port placement with needing to get IV chemotherapy every week in clinic. And then they might be traveling for hours and not have the ability to do that. They might not want to lose their hair. They might not want to feel nauseous. So they might prefer an oral medication, right? Or some people might not want or be afraid of some of the toxicities associated with some of these other medicines that we just don't know a lot about. And the effectiveness is really based on kind of data, but we really don't know. This is somewhat of my gestalt of taking care of a lot of children with desmoid tumors in terms of how they respond to these medicines and different modalities. But in reality, we need more studies in children to be able to know for sure. But because of all the long-term complications, the lifespan of a patient at this age, it's very important to weigh the risk and benefit of every single treatment that you're providing to a child. So for future directions, I think we really need to acquire a better understanding of the long-term side effects, and that really is difficult because when you run a clinical trial, you collect data for 5, maybe 10 years at the most, and then you pretty much are done, and it's harder to get that data down the road. And really, we want to know if a 5-year-old is on an investigational drug, 30, 40 years later, how's that child doing? And that's sometimes difficult to get. So we need improved reporting and publishing as well for the side effects. We need better, we talked about patient-reported outcomes. Many of those surveys are geared towards adults. We do have some that are geared towards children, but for desmoid specifically, that is a challenge. And then the registries that have been talked about already are a wonderful way to capture some of that data on a patient level. We also need to get more knowledge about desmoids in behavior in children. When we do studies, we generally collect tissue and we use that tissue to examine and study and try to learn why maybe desmoids behave differently in adults than children, or maybe why they respond to one drug and not the other. So I think there's a lot of biology that we still need to learn. And I think we really ultimately need to develop alternative, non-invasive, reliable methods to determine response rather than tumor shrinkage. And you heard, which is actually perfect that went before me, but that tumor board of talking about T2 signal and volume, these are exactly the things that we use as well to help guide us in addition to patient symptoms and quality of life and all the other things that are going on, not just the tumor being there or even growing. So I think the more that we can do that's non-invasive to find out how a tumor is doing, like not having to biopsy it again and so forth, would be a wonderful way to be able to assess how somebody's doing. So the key things I just want to hopefully get across is that children are not little adults. So they are very different. And certainly, if you have a 16-year-old, they certainly may act more like an adult. But even then, they're not quite as skeletally mature as an adult. And then there's other risks that you have to worry about. The side effects of any medical decision should be carefully considered in a growing child who has many, many more years of exposure to that therapy. And so I think it's very important to think of it in that context. The quality of life and goals of therapy should be weighed with every decision. So we always sit down with the patient. If I try to get as much, if the patient's old enough, to get their take on what they would want to do, as well as the parents. But every time there's a decision point, you need to have that discussion about what's best for that patient and that family. More clinical trials and long-term outcome data in children are sorely needed. And most importantly, my favorite, this is when we went to medical school, this is the first thing that they taught us, to do no harm. And I think, at least in taking care of children, that is the mantra that I try to live with every day. So every time I have a child in front of me, I try to do what I think is least harmful to accomplish the goal that we're trying to accomplish. And I think that's what many of us try to do in all facets of life, but I do particularly try to focus on that on children. So anyway, with that, it's a crash course on pediatric side effects.
Thank you, Dr. Weiss. A quick question on bone growth abnormalities on nirogacestat. Can you give a little bit more color on what your concerns might be?
Yeah, so I think for any of these targeted therapies, and same thing with the multi-tyrosine kinase inhibitors like sorafenib, pazopanib, there's some concerns of effect on the growth plate that could in fact growth, and also on the strength of the bones. So on at least the nirogacestat study, we're actively getting x-rays of the tibial growth plate, which lets you know we have baseline ones and then we have ones on study to see if it changes. And then we also are in real time collecting toxicity data on any patients that have any bone abnormalities, whether it's fractures or other problems. So that data will be reported in addition to the results. I mean, obviously people want to know the data of the outcome, like the ultimate outcome, but I think the toxicity data, particularly in children, is going to be even more valuable because of all the reasons we talked about. So there are ways that we monitor for those particular issues for patients on drugs, but those are the things that we most worry about: bone growth and then bone weakness, probably most commonly.